I'd like to invite the next speaker, Dr. Nagendra sir, who is a senior consultant at Buddha LASIK Center in Patna, and he'll be speaking on trifocal IOLs.
Thanks, Dr. Sajid, for giving me this opportunity. My topic is trifocal IOL. It was the Hofferke who was the first conceptualized the idea of multifocal IOL in 1982 when he noticed 50% descent IOL having 6x6 vision, and it was John Pierce was the first to implant bullseye type of multifocal IOLs in 1986. So multifocal IOL is basically a single IOL with two or more focal points and it different types like refractive and diffractive, and there is a combination of both the IOLs. Refractive IOLs for multifocal IOL is not in vogue right now because it has annoying refractions and glare halos, and it is people size dependent, and it is very poorly tolerated by the people who loving outdoor works. Again, this is not in vogue right now. Now comes the this leads to the development of diffractive multifocal IOLs. First diffractive multifocal IOL was introduced in 3M called 3M diffractive IOL. It utilizes the principle of diffraction in conjunction with refraction. What is diffraction? A little bit. Diffraction is a slight bending of light as it passes around the edge of an object. The amount of bending depends upon the relative size of the wavelength of the light to the size of the opening. If the opening is much larger than the light wavelength, the bending will be almost unnoticeable. However, if the two are closer in size or equal, the amount of bending considerable and easily seen with the naked eye. This technology had been used in the diffractive technology IOLs. This is the picture of diffractive optics of IOL, and this is basically a monofocal IOL, and diffractive element has been incorporated upon it. And this idea came with the Fresnel principle. Basically, it is a series of prism stacked upon each upon, and it bends the light to different focal point. Diffractive IOL, it is a addition. You can give the addition to the monofocal and diffractive element, and you can have a toric for corneal exposure correction in the monofocal, and can cover under the addition diffractive element for the can cover the interior or total interior surface or total surface of the IOL. Since these lenses have diffractive optical effect at all point of lens, even if the pupil is eccentric or deformed, lenses will always supply power for distance near vision. These lenses are pupil independent. So there is no fear of having glare halo. The biggest disadvantage of putting in multifocal IOL is the appearance of perception of glare and halos and loss of contrast. Otherwise, all the patients can be implanted. So basically, okay, the spacing of the diffractive element controls the power, and the height controls the light energy split, and the adjusting the height of the diffractive element can split the light into different focal point. So since the width is just to provide the near vision, then if it is doubled, the first order power would be reduced by the half. So this gives the intermediate vision of 1.66 diopter. So in bifocal diffractive IOL, the 40% are non-deviated light, that is called zero order, which utilizes for the distance vision, and 40% deviated light, just is called order 1. It is utilized for the near vision. So there is a 20% light lost, and this 20% light loss has been utilized for the intermediate vision, that is called second order diffractions. So basically, trifocal combines the two different profiles so that vision will improve at all spectrum. In trifocal, second order light diffraction is effectively utilized to provide the intermediate vision. Thus, beside gaining intermediate vision, there is a less loss of defocused light, reducing the side effect of such as glare and reduced contrast sensitivity. Here you can see consider the two diffractive element with two power. First element for near and second for intermediate. You combine both together can give the intermediate vision like this. So now comes the question of who are not the suitable of trifocal patients who are not suitable trifocal IOL. Of course, the previous speaker have covered the topic very well. And but for sake of completion, the airline pilot, truck drivers, taxi drivers, astronomers, patients with job requires activity at night are not suitable for the trifocal IOL, and the patients suffering from the glaucoma, ARMD, diabetic retinopathy, too much demanding patient, and those patients who have unrealistic expectation about the trifocal IOL should not be implanted. Of course, the objective measurement is very important for implantation of multifocal. There is a very less share of market of multifocal IOLs, but there are centers who have been implanting more than 90% of multifocal IOLs, because they are utilizing the chair time, and they are selecting the patient very well for the multifocal implantation. So objective measurement is a very important. This is like large positive angle kappa, that is nowadays called CORD. It is the visual axis and pupillary center, between the difference between the visual axis and pupillary center. Normally it is 0.3 mm nasal to the pupillary center. Again, Dr. Vishal has highlighted the importance of higher order corneal wavefront for over the 6 mm zone. So this is the data. You have to have optical biometer for obtaining this data. Here you can see that the Chang Wang cord is 0.3 mm, so it should not be more than 6. So here you can implant the IOL, of course, but in this case, in second case, this is again more than 0.6. So if you implant those patient having this multifocal IOL, may be appreciating more glare and haloge. Again, location of IOL is an ideal when it is centered in the visual axis and the pupil. That is called zero cord, but this is extremely rare and occurs when light reflex is dead center at the pupil. Then you implanting those cases, multifocal, there won't be any any problem with the multifocal IOL. But it is not the case. That optical most of the best compromise between the implanting the these two angle kappa, like pupillary center and angle kappa, you best compromise between your optical center, the lens center should come between these two. So if you implant this, if it is beyond that, then you have the light which supposed to go through the lens center strikes upon the periphery and give annoying halos and glare. So again, the higher order RM root mean square wave front error for normal vision cornea is 0.38 plus minus 0.14 over 6 mm zone. If it is more than 0.5, it degrades the optical quality and have high risk of halo and glare, even if you have implanted selected the criteria of the angle kappa. So those patients experience glare. So corneal quality of the corneal clarity is very important for implantation. If you can incorporate this data into your practice, then it is going to have a very good result of all the multifocal IOLs. Now comparison of trifocal technology, it is already just a little bit. It is already in the market, and the best part is that this utilizes the light loss into different focus of point. So accurate barometry is preferable all the time, and you use optical or immersion, and you have to, if you have to astigmatism less than 0.7 for the non-toric IOL, trifocal IOL you can implant. And of course the well-centered capsulorhexis is very important. Of course, so far the surgical technique is concerned, it is normal, you can use as routine and normal phacoemulsification in all the cases. So very meticulous patient selection, counseling and pre-operative workup to look for non-suitable candidates is key factor for successful trifocal IOL implantation. That way you can increase your practice of trifocal IOL by including more and more patients with freedom of glasses at all viewing distance. Thank you for your patience.
Thank you so much, sir, for that wonderful